Well, welcome to my office here in Daytona Beach. You've already seen the slides on the pain patterns, and Tina has agreed to help me with the demo. And during this COVID time, you see she's got her mask on and I don't, because if I put one on, then the voice might be all garbled, and it's good for you to be able to hear what I'm talking about. But always protect yourself and the people that you're working on. I've already sterilized my hands, and we're going to do some work. She actually has a headache issue with vertex pain, with what I would suspect, and I showed you in the charts, is most likely Sternocleidomastoid that can cause such a pain. And so we're going to see if there's something in the muscles that can verify what we suspect. And so instead of just targeting one muscle and going straight at it and trying to find the spot, I'm going to show you an overall headache routine that maybe you can add into what you already do. Some of you might have been taught, like I was with sternocleidomastoid, that you just grasp the muscle and squeeze it. It's a real unfriendly way to go about therapy. You know, if your person has body odor and you don't ever want to see them again, you might want to do such a thing, but I don't suggest that you do. There's easier ways to go about it, and that's what I'll be showing to you. So get some lotion on your hands, have your person supine on the table. You're going to be actually using their body weight as the resistance. I don't believe in having people prone on the table and pushing into the back of their neck and the back of their suboccipital area, because it's real uncomfortable and you can buckle their head forward. Get some lotion on the tips of your fingers and also on the backs of your fingers and even onto your fist, because I like to start off with what I call back knuckle strike. May I begin?
Yes, sir.
Let me have you move your hair up out of the way a little bit for me. Good. Now start with just some overall warm-up work. Don't target anything in particular right away. Make a mental note of whatever you feel, but don't go at it right away. Many years ago, I had a person on the table, because it's got to be a man thing. You know, we find something, we go straight at it like that. It's like, let's fix it. I know where it is. But it's not a friendly way to go about things. And she said, you know, it'd be nice if you just did some all-around easing work first. And so I've never forgotten that. I thought, you know, she's absolutely right. I targeted things too quickly. So you warm up things a little bit, go through the upper trap, because, you know, between the upper trap and sternocleidomastoid, those are two of the most headache-making muscles that people have. Now when you're doing, you can see what my hands are doing here, hopefully, because, you know, we don't have a cameraman. This is just set on a stand because of our COVID issues. And so you know how to go through the upper trap. Just stroke through it from the acromion all the way to the occiput, and do some all the way over to the spinous processes of the cervical area. Do the same thing on the other side. Sometimes I like to work only one side at a time, because some people have such an intense problem that they can't stand both sides going on at the same time. So make a note of what you feel. And so sometimes you can feel bony displacement. Sometimes you feel ropey strands. Sometimes there's thick areas and stuff that's tender in the muscle. And just make a note of it, but don't go at it just yet. Just do a little bit of work to warm them up. Now, what I'm going to show you in this video, we're talking about sternocleidomastoid, and I know that when you were in school, you were actually taught that the anterior neck was an endangerment site. There's probably nothing more therapeutic that you can do for someone than to work their anterior neck, because you have sternocleidomastoid, which is a major headache-making muscle, especially what people consider a migraine headache. And then right underneath them, you have the scalene muscles, which give you more pain in the torso than any other muscle. Pain down the arm, pain into the mid-back, into that rhomboid area. People are telling you to focus on rhomboid. A lot of times their problem's not there at all. Many times it is scalene medius that'll send a pain there. Posterior scalene will send pain out into the shoulder, down the arm, and so will anterior scalene. So, you know, somebody comes to you with arm pain and you're just rubbing their arm and getting nowhere, well, maybe you need to change your focus just a little bit. So, put some lotion on their anterior neck. Now you can turn the head. I'm going to turn her head away from you, which lines up the muscle a little bit better. Now you do have a carotid artery here, and so where you learned this was an endangerment site, find it. Find it on yourself. Find your trachea, then go off just to the side of it, and you know that the carotid is actually closer to the center, and we're going to be working more lateral than that, and so you don't have to worry about where your hands are that much. Start down on the sternum. Deep stroking effleurage is one of the best ways of getting rid of a central belly trigger point, and so you don't have to grasp this and squeeze it. Now, as I come up through the muscle, there's tension in it, there's thickness in it. Does this area hurt you?
It's tender.
Tender. Okay, so the thick area, remember from my explanation of trigger point earlier in this class, you're looking for the ropey strand, you're looking for the thickness, you're looking for the nodule. Your fingers aren't just smearing lotion on people, they're supposed to be searching. You're looking for an interference in the muscle, the contraction knot. That is the key to it. So stroke through it. Wherever you find a spot that's thick and dense, make a mental note of it, but don't go right at it at this time. Stroke through things a couple of times and get off. Go somewhere else. It was my way of doing things early in my career that I'd find something and it's like, oh, okay, I just dwelled on it and dwelled on it, dwelled on it and worked on it. Well, it's been my experience since that you work on something a little bit and then get off. Let it alone. Let people calm down a little bit, especially if it's a little tender on them. Through her suboccipital area, she's got some density here that's noticeable. You might feel ropey strands. Just go across some of that. Go in do little circles on that kind of stuff. If pressure is too intense, go around on that and just kind of stroke through it. And then go back to something that's a little more nice. Go back to doing something that's, you know, that's going to take the intensity away from what you're doing. Now, headaches a lot of times involve muscles of the jaw. And so what I want for you to do is put a little bit of lotion on your hands, and we're going to go through masseter just a little bit. If somebody gets a headache after they chewed Hard Rock candy or they ate steak for dinner and they gave their masseter a good workout, then, you know, if they get a headache after that, might make some sense to you. Some people from deep masseter get actually ringing in their ears, and a lot of times a distinguishing factor for that is if they open their mouth pretty wide and the ringing in their ears either gets better or worse. A lot of times it shows you lengthening the muscle or shortening it has a real difference. Does this hurt you?
Yes.
Okay, so she's got a nodule in the masseter muscle, and if I can give you one clue that's going to help you work on people with headaches in the future, split their head in half from your external auditory meatus forward, your ear hole forward. Anything that happens in that region, I want for you to be paying attention to sternocleidomastoid, to temporalis, and masseter, and sometimes frontalis. But these are muscles that a lot of times you just forget about because you don't add them in a lot of times to other types of body work. But when you're focusing on helping somebody with a headache, don't be in a hurry. You go through all this stuff and search and try to find what you're looking for. And you feel the difference in this side. Mm-hmm. This side doesn't have a nodule that this side did. Right there, you got one.
Yes, I
okay. If you want to, close your eyes. Let your fingers feel what they feel. A lot of people are just out there smoothing lotion and not paying any attention. But you're supposed to be looking for these spots. These are the center of the egg. Go along the zygomatic arch where they might have some real sensitivity from Golgi tendon organs that have a lot of tension on them, where the muscle has a tightness. So go across that. go right across the mandible where the masseter attaches and search that area. And she's got one heck of a ropey strand and a big lump in that muscle that you know has to hurt them. And so when you put pressure on it, when you're looking at their face, here I'm looking at the camera and talking, and so not exactly with the patient like you should be when it's just you and them. But you work through these areas, and when you see them wince, when you see withdrawal, one time I got socked in the stomach by an old German lady who called me a crazy man because I pressed on something and pressed on it hard enough that she struck me. So just be aware that that kind of stuff can happen, and work within the tolerance of the person that you have on the table. Now what you notice the next time that you go through upper trap, they'll notice that it doesn't hurt as much, that you didn't sit there and work it and try to wear it out. You go through the muscles and just kind of draw yourself through, feel what you feel. A lot of times the nodules will go away with some deep stroking effleurage, that you don't have to do that much else. Everybody's always looking for the damn silver bullet, something that's going to be the magic technique that fixes everything. Basically, you've got all the skills that you need to be a good therapist if you just put it together. You have the same tools I do: effleurage, petrissage, friction, vibration, percussion. Those are the 5 tools that massage therapists use with your hands. Deep stroking effleurage is just a gliding stroke. So you just glide through the muscle, feel for any interference that you have. Sometimes ropey strands will be gone even the second time that you go through. Does this hurt as much as it
No.
did before? So it's already eased up. Now when you're working through the upper trap, remember you got splenius capitis, splenius cervicus underneath. You got some spinal erectors that come through that area. You got quite a few layers of things. You're actually influencing all those things. But spend some extra time in the suboccipital area where you've got all those little muscles that have the very long names, like rectus, capitis, posterior major, and so the name is longer than the muscle. Work through all those things, because the size of the muscle does not matter when it comes to how much pain it can create. It's the intensity of the trigger point that might have developed in that host muscle. So the second time through here, this is a little bit softer, but some of the areas like this right here, you feel the difference in that?
Yes.
There's a definite thickness in this area. Now this is the second time, and I'm going to stop and put a little bit of pressure on it. How much pressure? Well, when you see their feet move, you know you did too much. When you see their eyes move, then you might be on the edge of causing some real discomfort. But I'm not sure where some therapists got the idea that some of this stuff was supposed to be painless. And I don't feel that I create any pain in people, but I'll put my finger on the pain they came in with. They came in here with it. It's just that I identified it. So I'm not creating it, I just locate it. And so as you press on these spots, what you're actually doing is blanching the tissue. You're actually squeezing the fluid out of these areas, and you'll feel them go down. And the people will actually tell you that they feel the sensation start to fade. What you're getting rid of is the cramp that has been held by that muscle, that is not helped by a pain relaxing drug. When you get a muscle relaxer, that's real good for certain things, but it can't always turn this stuff loose. And so pain relaxing drugs influence neurotransmitters, and they can make you groggy. You can have a lot of side effects from them and never get where you wanted to go when you have them. From me pressing here, has this eased up a little bit?
A little bit, yeah.
Okay. And so, how long do you hold on to a spot like this? Originally, I was taught 7 to 10 seconds. Originally, the book did say that in 1987. The next version that came out, it did not say 7 to 10 seconds. It started talking to a minute or 2 minutes or more. And so, the idea is to hold on to the spot until you made a change. Now, if it starts getting worse, it's a good idea to get your pressure out, that the body is actually rebelling and it's contracting and it's trying to shove your intrusion out. And when that happens, get out. Take your pressure off that area, but now you must go back to it at a later time because you started it. Now that you poked it, this is like riling up a bee's nest. And so they might have a busting headache once they leave your office if you don't go back and finish what you started. So you hold on to that spot until what they feel is just pressure, that there's not a pinch. There's usually a sharp pinching sensation to it when you first start. Have we hit that point yet,
I
Tim?
think so, yes.
Okay, now do you turn it loose? No, you don't turn it loose like the average therapist would. The text says that you increase your pressure again to be sure that you got it all. And sometimes there's more fibers deeper in the muscle that have a problem. You took care of the surface stuff that had splinted to protect it. But then you have to press and be sure that you got it all. Is there any discomfort there now?
No, it's a lot better.
Okay, so we got rid of that spot. Now, you know, you never get tired of this kind of stuff. Search around until you find as many things that hurt this person as possible and hold some pressure to them. And it's a funny thing that in the beginning, it hurts them, and it doesn't take too long to where they want you to find it because they actually instinctively know that you're helping them and they start guiding you to it. So you push a little more this way and a little more that way, and I'm sure that has already happened to you at some time while you treated people. Now my right hand is taking a break and my left hand is working on the left side of her neck. A lot of times when you get a problem in a muscle on one side, you look at the same thing on the other side. And many times they've got a twin. And so you go to the other side and you make sure that that side is also relieved. Now, some of you were also taught that you take their head and push their chin towards their chest. I was shown that too, but it's not something I would suggest. If somebody has ever been in an auto accident where their torso is held back by the seat belt, but their head is allowed to accelerate and thrust forward, a lot of them have disc problems that are underlying their muscular issues. Sometimes the muscles splint to protect what's underneath it. And if you take their head and push it towards their chest, you'll actually posteriorly displace the disc material and you can cause them a problem. So I don't suggest that you do it. Just take their head and turn it a little bit. Just put their chin down towards your chest, and what you do is just open that area just a little bit. Do it to yourself and feel what happens there. And so we went through sternocleidomastoid in the front of the neck a few minutes ago. Let's go back through there now and see what we found. Now see, we haven't been sitting there working it. It's had time to relax. It's had time for new fluid to get in. We stroked it a couple of times. Nervous system calms down. Fluid exchange has happened because you shove some fluid out and something new has to fill the void that you just created. So now let's go back through the front of the neck. I'm going to turn her head a little bit towards my left and go back through SCM. Just use your 3 fingers and do some gliding. Start on their sternum. You know, you've got 2 divisions here. You've got the sternal division and the clavicular division. Right in between them, you can access some of scalene medius. That's really not part of a headache muscle. That muscle does, or headache class, that muscle does not refer pain to the head. Everything goes to the torso. But what you can do is take your finger on the transverse processes and just move sternocleidomastoid to the side, and right there underneath it, right on the front side of the transverse processes, you're going to locate scalene medius. When you do that, a lot of people say, oh, that's that pain I get down my shoulder, down my arm or into the shoulder. And if you locate a spot that gives them the referral that they recognize, you found pay dirt. You found exactly what you were looking for because you recreated the symptoms that they have, and there's no other reason that that would happen. It didn't happen when you pressed anywhere else. It just happened when you pressed on that thick, dense area in the muscle that started to refer the pain that they get, and see if they don't get better from that very thing. Take only 1 finger and go through that area if you need to. You have a jugular vein out here. You don't have to worry so much about that. You know, we scare you to death when you go to basic school to keep the public safe, but the more experienced you are as a therapist and the more you know where your fingers are, the more you can work in all these endangerment sites. Go across the occiput area and the mastoid process, use your fingers to pull some of the muscle into that area to relax the Golgi tendon organs and to take the pressure and the strain off of them, and go back to a couple of long strokes on the muscle itself. Now, even if you find a nodule, I don't much suggest that you stop and squeeze it. It's a miserable thing to happen. Try it on yourself if you want to, but it's a terrible way to work on things. Just do some stroking. It actually will relieve the problem if you do it in a repetitious way. Some of this stuff you might want to do this routine 3, 4, maybe 5 times. Now I'm going up the left side because she actually has vertex pain, and so I suspect this muscle as being the cause when it really gets annoyed. Now when you have a headache, you have a referred pain. What you have is an active trigger point. Active trigger points refer pains to distant areas. A latent trigger point only irritates its host muscle. It'll still be tender when you find it, but on that day, it is not referring a pain somewhere else. It didn't mean that it went away. It just means it's latent, it's quiet, it's sleeping that day. But a quick movement of the head, something you do with looking up over your head that stretches the muscle, something you do looking down which shortens the muscle, either extreme, long or short, is enough to irritate a muscle that has a trigger in it. So always remember that kind of things is some of the basic rules of working on muscle. And so stroke your way through. Now remember that she had a spot in her masseter that was causing her a problem. So let's go back and see if there was a difference there. Now what I don't suggest on the face, don't go down on the muscle. Nobody likes to have bulldog cheeks, and so don't be pressing tissue down. Always be working either backwards or upwards. And so go across the area and to see what you did. Now there's still a little piece of it, but it's not near like it was, is it?
No.
That's a whole lot better, and we didn't even do that much on it. Now what I have learned over the years is the more that you dwell on something and beat it, the more resistant it sometimes gets. And so you stroke it a few times until sometimes you start seeing resistance. You start seeing their feet move, their hands move. Sometimes their head moves and they're trying to get away from you. Stop, get off. Go to another place and come back to it. And you'll notice that if you do that a couple of times, eventually the body will allow you to do what you're doing. You can't force your way through all this stuff. Some of you that went to a class on deep tissue therapy, you got this idea that the harder you press, the better it's going to be. It actually is not. You want to be focused and you want to work specifically on the problem in the muscle that really needs it. But the amount of pressure doesn't have to be hard. All you have to do is be more intense about where you press. I want to find the spots that need me. I don't want to just indiscriminately put pressure all over stuff that is basically normal and doesn't need that much pressure. When the state changed the description of massage in Florida from the superficial tissue of the body excuse me, to the soft tissue of the body, that's when the term deep tissue therapy came about. It's actually more of a marketing gimmick than it is actual therapy, because what is deep tissue to one therapist is not to another. It just depends. It's very subjective kind of a phrase. So right there is a little spot in her masseter. I'm just going to hold some pressure to it because a lot of this has cleared out. And so don't start pressure from the beginning because you haven't cleared the muscle. You know, sometimes you have to blow out the smoke before you can find where the fire is. And that's why you go through things a couple of times and then you locate the real spot that might be causing it, that it'll shrink down the more you stroke through it. Is that feeling better to you?
Mm-hmm.
Cool beans. Now I talked about doing temporalis. You got lotion on your hands. You don't want to be putting lotion all through somebody's head. So take the take the covering that you have on the headrest and use that. Now, temporalis is a convergent shaped muscle, converging fibers. The most anterior ones are vertical, and then they are in varying stages until the most inferior ones right on top of your ear actually are horizontal. And so they go in a fan shape. And so take your fingers and put all four of them together, just like I have here. Put them underneath your cover and just go up and down and back and forth on the muscle. And you can do some small circles at the same time. Circles are not quite so intense, but they'll get you there just the same. And so as soon as somebody doesn't like pressure, if they resist that, turn it right away to a little circle. You'd be surprised how they ease up their resistance. Just hurt you at all through here.
But, yeah.
You know, when was the last time anybody worked on your temporalis or your masseter? You got a little glitch in it right there.
I feel it.
Now, if you're pressing on a spot like this, okay, so you found a little spot in the muscle, and you know that you've probably found a trigger because they've got a contraction knot and they've got that ropey strand that I talked about earlier in the class. Stop and apply your pressure, and if they start to feel a pain, if it gives them a pain that they recognize, like I said before, then you found something significant. Go back after the treatment to your body chart and make a note of that. Put an X on your chart where you found a spot like this so that you can look for it the next time that they come in. It has happened to me that on the second visit, somebody would come in and say, well, I don't know that I'm getting any better because I still hurt over here. Well, that wasn't the pain that brought them to me. They had something completely different, and had I not charted it, I would have forgotten it myself. And of course, they're not going to remember. It's a good thing that we forget about pain sometimes once it's gone. Sometimes I will ask people, when was the last headache you have? They don't even know. They weren't even sure. But if they get them on a daily or weekly basis, then it's real obvious to them. A man who was in a building who was very close to here came to me. He was about 72 years old at the time. He said that he would describe his headaches as migraine. Remember, migraines have what we consider to be autonomic phenomenon. And so he said that he laid in his bed part of 6 days a week in a dark room because he was very sensitive to light. And he laid there in the bed with an ice pack on his head. And that was what his life was about. And so he sees my window, my front window of the office, that said that I specialize in headaches. And he called me and he said, you know, do you think you can help me? Well, I don't know. You know, all we can do is make an attempt here and see if it's muscular. Well, this old fellow was an ex-professional boxer. He got punched and hit in his face and the front of his neck how many times during his life? His muscles were insulted. And so sternocleidomastoid was what I suspected because he had vertex pain, was what he complained about the most, and pain over his eye. Do you remember the chart that I showed you that showed those very things? So as I'm working on the muscle on the one side, as I stroked up through it, down low on the right-hand side, I'll never forget this, as I press on the nodule that he had, excuse me, he reached up and he tapped the top of his head. I said, do you recognize it? That pressure was eliciting the pain that he recognized. He said, that's part of my headache. On the other side, as I stroked through the muscle, I stopped high up near the mastoid process, and he had a thickness, and I stopped on it and just put pressure, and he reached up and he tapped over his eye. I said, do you recognize it? He said, that's the other part of my headache. Do you know, I gave him 3 treatments and he went 6 full months with no headache. Now that's the bomb. So don't ever underestimate what you can do for somebody by locating something that nobody else out there in the medical field is even bothering to look for. The books that I showed you at the beginning of the class, if you don't have them, if you like to do this kind of work, I suggest you get them. If you can't afford them, at least look at the charts and print some. You can find them on triggerpoints.net. will have all the charts that I use. When people tell you where their head hurts, it'll give you a list of the muscles and show you what the pain patterns are that have all come from research that's been done. We don't have to recreate the wheel. Just learn the basic pain patterns and it'll get you in the right neighborhood. Not everything is absolute. Not every muscle is identically in the same pattern, but boy, there's something close. Right there, I feel a little something else.
Yes.
And so she got another spot in temporalis that's a little gritty spot. Now, how many times do you feel something ropey, sandy, bubbly? You know, they exhibit themselves in such strange ways, sometimes almost like a grain of rice that's in the tissue that you can kind of crick over. Those are usually real intense. And so just stop and do some pressure or go in some little circles on it if the pressure is too intense, because if you watch their eyelids, which I'm not doing because I'm paying attention to camera and various things, then you're not as with the patient as you normally would be. But just as soon as you create some intensity, go back to doing something a little more nice and ease them up again. Let their fanny relax a little bit, let them breathe a little, and to lower themselves back down to the table. It's always a good idea. Stroke through upper trap again. By the time you go back the third time, you'll be surprised how a muscle will turn to butter, and you really haven't spent much time on it, but it is the repetition, to me, that makes this method work. Go back more times. I know because you were taught Swedish massage, you were also taught that once you finish a body part, you don't go back to it. Well, this is not Swedish massage. This is for pain relief. And so the more times you go back to an issue, the more times you go back to a problem area, the more it will give you with the very same amount of pressure. You don't have to keep pushing on it because the surface has relaxed enough that the same pressure is allowing you access to deeper fascicles in a muscle. And so I don't do what people would consider deep tissue therapy. I'm always working at the same pressure. The body gives it to me. You're not taking it. This unit that people live in will resist intrusion. And the more you try to force your way, the worse it gets. So just do some overall nice work. Go back through sternocleidomastoid. You can have them slide and shimmy towards you and kind of hang their head a little bit off the table if you'd like to put a passive stretch on the muscle. Most of the time, the first treatment, I choose not to do that. I don't want to do anything that's too extreme or too excessive. I don't know if they have underlying disc issues. Sometimes they don't even know that they've got other problems. And so if you made a difference, if they used to get one headache a month or a week and now they get one a month, then you made a difference. If when they get a headache, it's not as widespread, it is not as intense, it doesn't go as far as it used to. All of that kind of stuff matters. Like here on the top of your shoulder, you got, she's got a real spot here in pectoralis minor as it comes just underneath the clavicle. And so I stopped to put a little bit of pressure on there. So your hands are not smooth and lotion. Your hands are looking for something. Your fingers should be searching. Have little eyeballs in the ends of your fingers and be searching through. Close your eyes and use your fingers, without looking. And just make your body pay more attention to what it's doing. Go back through the suboccipital area. Be sure that you have cleared it. If they've still got a thickness, like right here, you have a little piece. It was a whole lot bigger before, but it's actually, it probably doesn't hurt you near as bad now.
No, it doesn't.
So see, the intensity starts to fade. Actually, people that didn't like you at all when you first started will get to liking you by the time you're done, because in only a few minutes time they'll start to forget how bad it hurt the last time you pressed there. So go back through your routine. So what I suggest that you do, sternocleidomastoid, masseter, temporalis. You can do frontalis. You can go through their forehead with your thumb, pull the skin towards the outside. Remember, that's a circular muscle that actually doesn't move bone. It only raises your eyebrow. And so go go through that because you can get a real frontal headache, just like a baseball sitting right on your forehead from not only frontalis, but from sternocleidomastoid to give the very same pain pattern. And so be sure that you go through them. You do the upper trap, you do the suboccipitals, the posterior cervicals, then you can turn them over and do an all-over back routine. You start with lower trap and work your way up, because lower trap doesn't refer pain to the head, but it does refer pain to the top of the shoulder. And if they have a trigger here in the top of the shoulder, it might start further down. It refers to here. You know, one place calls the next one on the phone lines of your nervous system, and all of a sudden they're having a party at your expense. And so if you can stop that kind of stuff when it begins, the person can be a whole lot better. So you turn them over. I don't need to show you these things because you already know how. But start on the lower trap, middle trap, upper trap, and then work carefully up into the neck without jamming their face and buckling their head down into the face cradle. And I hope this has been helpful to you, and thank you for watching. Okay, that's it.